LV pseudoaneurysms after myocardial infarction. This case was reported in NICVD Karachi and already been published in JAC 2025. So my patient was 56 years old man who presented with 2 days history of profuse sweating and shortness of breath, NYHA class 4. He had been admitted 1 week prior for stabilization owing to acute decompensated heart failure secondary to reduced ejection fraction. So the patient's past medical history was significant with long-standing 10 years of hypertension, the ischemic stroke 3 months back, and inferior wall MI 4 months back, which was treated medically on patient's request. And surgical history, he had the inguinal hernia repair 10 years back. During the current admissions, the patient's GCS was 15/15, and on positive general physical examinations, chest auscultation revealed bibasal crackles and was a bit tachycardic with the heart rate of 104 and respiratory rate was 30. And the oxygen saturation was 98% with 10 liters of per minute of supplemented oxygen. Laboratory investigations were normal except for an elevated high sensitivity troponin, and the EKG showed T wave inversion and in inferior leads and V3 to V6, which were consistent with the previous findings of previous admissions that was 4 months back in some peripheral hospital. And chest X-ray showed the findings of pulmonary edema and there was a cardiomegaly. So we done the transthoracic echo portable study in emergency department. This is the parasternal long axis view. This is the LV cavity, the LA mitral valve, and the echo showed akinetic inferior wall, inferior lateral wall, inferior IVS, and mid-anterior lateral wall with moderate LV dysfunction with the visual estimated ejection fraction was 40%, and there was a aneurysm arising from the basal inferior lateral wall, which was multi-cavitated and interconnected with bidirectional flow on color Doppler imaging. And there was large posteriorly there was a large pericardial effusion posteriorly around 28 mm with there was echogenicity there, likely that was the coagulum that was closing that impending rupture likely. This is the same parasternal long axis view diagram shows the structure identification, and these red stars shows the multi-cavitated pseudoaneurysm, interconnected cavities, all three. And this is the pericardial effusion. Play कीजिएगा. So this is again the same parasternal long axis view. This is basically the neck of pseudoaneurysm, and which connects to this large pseudoaneurysm, and these interconnected to other cavities, which with all three cavities are basically interconnected. ये बेसिकली हमने थोड़ा सा मॉडिफाइड व्यू लिया था कैविटीज को फोकस करने के लिए. तीनों कैविटीज इंटरकनेक्टेड हैं एंड द कलर फ्लो तीनों में उनमें जा रहा था. pseudoaneurysmal cavities. प्ले कीजिए. This is the apical four chamber view. The aneurysm basically was from the basal to mid inferior lateral wall, extending up to the anterior mid of the anterior lateral wall. Play कीजिएगा दोबारा please. which is confirmed by this
बाहर से उसने
apical
LA को
four chamber. Yeah, aneurysm.
बाहर से उसने LA को compress किया हुआ है ना बहुत सारे.
So same, these are the echo findings. The aneurysm size was on transthoracic echo was 107 by 80 mm, and the neck was 18 mm, and the color Doppler shows bidirectional flow across the neck and large localized posterior pericardial effusion around 28 mm, and there was a moderate secondary MR. So we, for confirmation of our findings, we did this cardiac CT axial view, which shows. Chalaiga, please. This is the, ये भी आपकी सीडो एन्यूरिज्म कैविटी है, and this is the large, the primary cavity, and these two interconnected cavities. This cavity was likely was a thrombosed one. ये सेम उसकी जो हमने एक्सिल व्यू की पिक्चर थी, ये फेंक दीजिएगा. ये 3D रेंडर्ड हमने जो है रिकंस्ट्रक्शन एक वीडियोस डाली थी फॉर. चलाइएगा. सो बेसिकली ये दोनों सीडो एन्यूरिज्मल कैविटीज हैं. नेक्स्ट प्लीज. So cardiac CT reveals the large outpouching from basal to mid inferior lateral wall of LV. The neck was 22.2 mm and was around 12.5 mm apically from the mitral annulus. And there was a small pericardial effusion posteriorly. Next, please. So we did the cardiac MR for confirmation of etiology, which again shows the LV, the aorta, and these are basically the three interconnected pseudoaneurysmal cavities. And the CMR also shows or confirm our finding of ischemic etiology as the inferior and the inferiolateral was hyper enhanced on late gadolinium imaging. ये भी चलाइए. ये बेसिकली शॉर्ट एक्सिस व्यू है, ये इंटरकनेक्टेड कैविटीज हैं. So CMR finding consistent with our previous findings of transthoracic echo and cardiac CT. The late gadolinium enhancements in the inferior and inferiolateral segments showing ischemic etiology. So before the final management plan, we did the left heart cath. Here is the left heart cath. Play, please. So the left heart cath shows the around 50 to 60% disease in the mid LAD. Next, please. And around moderate disease in osteoproximal circ. The RCA had mild disease in midsection around 30 to 40%. So the management plan after multidisciplinary heart team discussion was made of coronary artery bypass grafting with Lima to LAD and saphenous venous graft to OM1 and aneurysm repair. After discussion with the patient and his family explaining the risks and benefits, the patient and family elected to pursue conservative management. Patient was admitted to ICU and was managed and stabilized according to guideline directed medical therapy. And on subsequent follow-ups, after the initial stabilization, the patient left the hospital against advice and was unfortunately lost to further follow-up. So, in background, the LV pseudoaneurysm is a serious complication of myocardial infarction occurring only in 0.2 to 0.3% of the cases, and multiloculated pseudoaneurysms are even rarer. So, around less than 0.2 to 0.3% after myocardial infarction. So, the take-home message is multidisciplinary imaging or multimodality imaging is invaluable in diagnosing this multicavitated pseudoaneurysm. Combining transthoracic, cardiac CT, cardiac MR improves the diagnostic accuracy, influences surgical planning, offering valuable insights that affect the treatment, decision, and prognosis. So here is the DOI link for the future
Time is
correspondence-
up.
Good. Time is up. Chalo.
Thanks.